Kane, we can see you. Can you see? Can you hear us okay?
Hello, morning, Las Vegas. Hello, Chris. Yes, I hear you very clear, very loud.
Okay, Kane, let me introduce our panel, and then we look forward to hearing the case that you're going to present. So we have a super panel here. We have Herb Aronow, Robert Morgan, Jihad Mustapha, Constantino Peña, Darren Schneider, and Martyr Werner. So we can see you. Go ahead and take it away and let us know what you've got.
Okay, thank you very much. First of all, it's an honor for me to present our team over here. I'm here with my good friend and colleague, vascular surgeon, Dr. Callaert. We have the two nurses, Hilde and Kim, and so also our anesthesiologist is present in our hybrid room. So Joren Callaert will present to you the first case from Dendermonde.
Hello, so we selected for you a patient, a male patient with a heavy calcified common femoral. Next slide, please. Yeah, thank you. Very calcified common femoral artery on the left side. On the history, he has had in August 2015 a PTA of his right common femoral artery and stenting. And on the left side, we already treated him with DCB and stenting in the left SFA. He has classical risk factors, and now he presented himself with a severe claudication of his left limb with an ABI of 0.42. Next. On the angio-CT, we see on the left side the heavily calcified common femoral artery. Next. And on the MRA, which was taken 1 year ago, we have this lesion in the common femoral, and in the popliteal artery, there's also a lesion on the left side. So the plan is to go from the right groin to the left side to predilate the common femoral artery with armada balloons, and then see what the result is. Probably we're going to implant a supera stent in the common femoral artery, and then we're also going to treat the popliteal artery with the Stellarex DCB balloon. Okay, next. Okay, Koen.
So, thank you very much, Joren.
Hilde.
So, what we always do in preparing these kind of cases is to prepare the case very clear, very in detail on our pre-op imaging. Here you can see our pre-op CT with our workstation of General Electric. We are working with a Discovery 740 machine. We are doing this preparing work, and as you can see here, we use a very nice tool to create a center line tracking. So with a very intuitive maneuver, we can remove the bone from the CT scan so that we have only our vessels. And so based on these, you can make a very nice center line tracking. Over occlusions, you can use a bridging tool over occlusions in order to fuse at the right moment, to fuse in the real images. As you can see here, this automatical center line tracking is done very intuitively. And so then afterwards you can create subvolumes. You can also add markers, for instance, where the lesion in the common femoral on the left side is starting, markers where the profunda ostium and the SFA ostium is. And so then with the by-view registration, we're gonna fuse this in our live images. So we are always performing these kind of preparations in advance in order to be guided in an optimal way during our procedure. In this way, we have already the experience of 6 to 12 months with this system. We notice that there is a reduction of contrast, a reduction of radiation, and an increase of the safety of our procedures. Okay, so As Joren explained, our plan was to start with a right common femoral axis, and already here you can notice that this was something special. Can we have sequence 1, please? So to show you, there is a stent, and a vascular mimetic implant is right in the right common femoral present. So in earlier times, and especially as vascular surgeons, we were very reluctant to implant stent material in the groin. First of all, because it's an access site, and so because of this, nowadays we overcome a little bit this problem by implanting, if necessary, a vascular mimetic implant, the supera here in this case, where we can puncture in a quite safe, quite accurate way. You know that this is just 6 pairs of nitinol wires, so the wires are not really damaged by puncturing between all these wires. Next, you see that it's quite easy to introduce also our little access guide wire, and afterwards, next also our 6 French sheet, as you can notice here. So in terms of access, this is in our hands no longer a contraindication for stent implantation in the groin. Afterwards, we are performing a crossover procedure with a rim catheter of Cook, and we are using here the Thermo glide wire 035 to perform this crossover, and we introduce a 6 French 45 centimeter Thermo destination as a working sheet in order to start the procedure on the left side. Are there, right up to now, in terms of strategy, access, and so on, questions or remarks in Las Vegas, please?
So, Koen, this beautiful demonstration of both the technology you have with the CT scan as well as the access of a supera stent in the common femoral artery. I'm going to get the opinion of panelists here. So Darren, you're a vascular surgeon as well, okay? And I kind of know where you're going to sit here, but we'll start it out with interest. You've got a vascular surgical colleague who's done a beautiful job with the right common femoral artery and implanted a stent. You saw the heavy calcium adjacent to the stent. What do you think is your role? How do you decide common femoral artery endarterectomy versus endo procedure?
Yeah, no, I think that's a really great question, and I think that this is a remarkable demonstration of how the technology is advanced, and I think we do have some additional options. I'm still in a place where probably my primary approach to common femoral artery disease, especially heavily calcified, potentially involving the femoral bifurcation in a reasonable risk patient with longevity, is still going to be addressed with an endarterectomy, because we know we get terrific durable results. I mean, I think, for example, this patient already had a DCB treatment of that common femoral, and he's basically back with that lesion. I think I agree with the strategy. If you're going to tackle it, that you probably do need scaffolding, and I think the supera is an excellent choice. And I think the other thing is really it's important to emphasize the preparation that they've used. Yep. In terms of planning the case and the use of the fusion imaging and taking advantage of that technology as well. Really, in complex cases, makes a big difference.
Great, thanks, Jay. So, Koen, we're watching you as your wire here, and looks like you're starting with a balloon here, guided by your CT scan. Tell us what you've got there, please. What wire and what balloon?
Okay, so probably I can share it you. We also made a breeze registration with our discovery. So can I have the sequence, please, of the breeze? Then we can look together at these images. So you see that there is a triple vessel runoff at the below the knee area. You can judge already the lesion in the common femoral and the proximal SFA, and also in the popliteal, there seems to be a quite high-grade stenosis. We can give you a little bit more details. Next sequence, please. So to focus on these common femoral. And so here, I think you can agree with me that there is really a bunch of calcium on this common femoral and also in these proximal SFA. So really coral reef. And in order to pass this, I selected immediately an 018 guide wire. This guide wire is one of my favorite guide wires to do this work. It's an Advantage Thermo guide wire 018. It's a kind of hybrid wire where you have the first 25 centimeters, a very soft nitinol, what is very durable, where I can make a loop afterwards, removing the loop, whatever. I'm always using the fast spinning technique in order to stay intraluminal, or try to stay intraluminally. Also in this case, I use this technique. So you have a perfect grip on this Advantage wire, what is foreseen with a spiral width EPTFE looping around the wire. So it gives you fantastic grip, and you can easily use the fast spinning technique with this wire. Also, and these were the images that you've seen, I was perfectly guided during this procedure. Can I have the live image, please, now? By the markers we've made in the beginning. So I added an orange marker on the proximal part of the common femoral, the lesion, in fact, and a green marker on the ostium of the SFA, and a yellow marker on the profunda. And so it was for me quite easy to steer my wire from the orange to the green marker, so I don't need to add more contrast, I don't need to make more road maps and subtractions. So really restricting contrast and radiation.
So Koen, educate us there.
Afterwards, I start...
No, go ahead, finish, go ahead.
So afterwards, like you can see, and this is the phase where we are, you know how important it is to prepare the vessel. In my opinion, it's not only important before the implantation of a supera, but also before the use of drug-coated balloons, other regular nitinol stents. I pay a lot of attention to this vessel prep. And so, based on this, I'm performing an angioplasty here in this quite big common femoral artery with a 7 millimeter diameter Armada balloon of Abbott Vascular, 7 millimeter and 4 centimeter in length. Also here, I have the markers to be guided in terms of choice of my balloon length and diameter.
So Koen, the green line and the yellow line, fluoroscopically, the calcium of the profunda would seem to be higher than the yellow line. Is the yellow line the ostium of the profunda that we see on the screen?
It's not really the ostium. Let's say it's like 1 centimeter in the profunda. It just gives me an idea about the direction. So if I'm doing the recanalization and I see that my wire is going in the direction of this yellow circle, then of course I need to re-steer this in the other direction, the medial direction. But it's not really a marker that I'm going to use during the stent implantation. Next balloon, Hilde.
So let me get some opinions of the panel here.
The 7 millimeter here was quite undersized.
Yep.
So I'm going to upgrade this to a bigger balloon size, immediately up to 9.
As you're doing that, Koen, let me get the panel involved here. Jihad, you know, you do a lot of orbital atherectomy, but this is a big artery. You know, you just saw a 7 millimeter balloon, but there was also the coral reef in the SFA and downstream in the Popliteal artery. Is orbital atherectomy have any role in an artery this big with a calcium that involves a bifurcation in the profunda and the SFA? What do you think?
You know, Chris, here, this is 2 different atherectomies I probably would have considered here. One is the larger crown orbital atherectomy is one, and the second one would have been a directional atherectomy, calcium cutter. So the 2 would have been a good options in this case here.
And even Jetstream will work in heavy calcium as well, which would be another option with the bigger. So there are those. Herb, with this calcium, you saw the runoff and you see the aggressive nature of angioplasty here. Would you think distal protection has any role here or not?
Yeah, I don't think you would lose anything. There's certainly the potential for distal embolization. But if I can, I just want to maybe comment on your last question to Jihad as well. I guess the question is, have we exhausted non-stent therapies in this location, right? This is somebody who a year earlier had a drug-coated balloon. Would the result have perhaps been better if there had been atherectomy performed before that? And we don't know, right? There's a lot of debate around that issue. Is it worth trying atherectomy and DCB here instead of a planned stent. In other words, should stent be reserved just for bailout alone? So perhaps if I seem skittish about the stent idea, it's just simply because that hasn't been my approach. I'm intrigued by the approach. And I don't know if there are data either way to argue for or against.
All right, Koen, so that was what balloon that you just used?
So the last balloon that I used was a 940 Armada 035. And so based on this, I even asked for a 1 millimeter bigger balloon in order to have the perfect vessel prep. And I'm using now a 10 millimeter Armada balloon, 40 millimeter in length.
So, Martin, you did a lot of Supera work with some masters like Koen in Leipzig. Tell me, in Europe, what's the biggest Supera you have? And is it going to be big enough for a common femoral artery that's being prepped with a 10 millimeter balloon? And is that a strategy that, what do you think of the Supera stent here and the sizing and what you'd think?
Yeah, well, personally, I haven't put the Supera into that region until now. I've seen some cases that went well. Sizing might be a problem. If you have a 10 millimeter vessel, there's certainly no Superas with that size. But what I've treated within the last year, I had 2 or 3 patients treated with a shockwave device in that area, having still in mind that a stent in that area is still perhaps not the best or first solution I would go for. And these results were quite good, although they are anecdotally. Patients are doing well. In the follow-up, I had no restenosis within that year, and the luminal gain was excellent.
That's great. And we just had that approved in the U.S. here within the last week, so it's nice to hear your experience was positive there as well. So 10 millimeter balloon, Tino. So it looks like he's committed to a stent strategy if he's going up with a 10 millimeter balloon. What if there's a dissection in the proximal SFA? Any ideas of stent strategies if you have to go cover dissection? What do you think?
Yeah, I think it's an interesting question. You know, it looks at it now like we're dilating over the origin of the profunda. So we've decided, I mean, I think one question is, are we going to cover the origin of the profunda? And if there is a problem with that or not in this situation. And then if you have to extend a dissection in the SFA, I guess you would be prepared to stent that. I think you could continue with a Supera, or you can use any form of really, you know, any kind of self-expanding stent. I think attacking that proximal profunda doesn't look very calcified.
Great. So, Koen, we see the result. You got good vessel preparation, and really surprisingly, I don't see any dissection. So what is your next step, please?
Yeah, it's a very nice remark, Chris. And to be honest, the reason that it's also my experience that even with aggressive angioplasties, the rate of dissections is really decreasing. And this is because I adapted my technique of angioplasty completely, where we did in the history, where we did very fast, powerful inflations, short inflation time, immediate deflation, pulling back our balloon. Nowadays, we are doing this a little bit more in a relaxed way. I mean, we inflate the balloon step by step, 2 per 2 atmospheres. We leave the balloon there at least for a couple of minutes, 3 minutes if possible, and then afterwards we are also deflating the balloon completely just before we are retracting the balloon. And by using all these little steps during the angioplasty procedure, I noticed that the rate of major flow-limiting, major grade 4, 5, and 6 dissections is really decreasing. So nevertheless, this patient was treated with a drug-coated balloon earlier, and we noticed that after 1 year it was already restenotic or occluded again. So based on this, we're going to implant Supera here. The biggest Supera available is 8 millimeter. And the 8 millimeter Supera, so what is inner diameter, it means that the outer diameter is around 8.7. So I'm quite confident that this is gonna treat the lesion in the perfect way. Unfortunately, this 8 millimeter Supera is not going through a 6 French, so we need to upgrade. You can do this, Joren, already with an 035 exchange for a catheter to an 035 wire and introduce a 7 French sheet.
So while you're doing that, this is a beautiful demonstration of good angioplasty. I mean, we just saw a 10-millimeter balloon in a calcified common femoral artery and no dissections. So all your points are very well taken. For the U.S. operators, it's important to know that once this stent got approved in the U.S., unfortunately, the FDA, because the 6.5 millimeter superior was the largest one used in this trial, they did away with the 7 and 8 millimeter superis. So before you take a 10 millimeter balloon in the common femoral artery in the United States, realize that the biggest superis stent we have is 6.5. They took them from my shelf with tears in my eyes because we can't do that anymore.
Chris,
So,
I want to add something, if you don't mind, quickly. One of the things that Dr. Deloose showed here is the sequential angioplasty. I want to make a comment on that. The sequential angioplasty reduces dissection by 27% in calcified lesions. So it's a great demonstration, and I encourage the audience to try that. So lower profile balloons and then go up slowly, just as he demonstrated. It's a great technique.
Thanks, Jihad. So, Robert, I'm going to get you involved here as well. So while they're doing that, we'll watch them. They're doing an 035 exchange, which is really important to just take their time and exchange through that stent. Tell us any other thoughts you'd have in this common femoral artery. Is there any role for focal force or any other strategies that you'd have? And would you do anything with the profunda?
I think I'd carry on doing what we're doing here. I'm pretty impressed with the fact they used a 9 millimeter balloon in the common femoral artery, but the result looks great. And I'd probably stay with that result now rather than put a stent in. I have to say I'm concerned about the effect of the stent on the origin of the profunda, because already the origin of the profunda looks slightly more narrow than it did at the start of the procedure. So I'm a bit concerned about the profunda.
Great, thanks, Robert. So Darren, okay, coming back to our vascular surgical colleague at the beginning. So you've got a superis stent in the right common femoral artery, and it goes to the bifurcation at least, okay? Now you're getting pretty good results here, but it's already in a DCB. Any concern that you have of bilateral common femoral artery stents near the bifurcation? Is that going to be a problem, or as long as it's patent, it's going to be fine?
You know, probably as long as it's patent, it's going to be fine. I mean, I think that, I mean, he's shown us a nice example of how he can come back and access through that stent, and I think that in terms of stent selection, I think that that's a good choice to be able to do that. I guess if you had a patient at a AAA and you're going to come in with big sheaths to do an EVA or something, that might be an issue, but then you're probably going to be doing a femoral endarterectomy for access anyhow in that case, and you could do an endarterectomy and still remove that stent. So this is not the necessarily the end of the story. I do have the same concern because you see that calcium. I mean, this really is a bifurcation lesion, or a lesion involving the bifurcation with that heavily calcified plaque burden at the bifurcation. And we'll see, Koen's doing a great job, but in terms of treating that, if you're going to jail the profunda and what implications that's going to have.
All right, Koen, back to you. First of all, you made that look so easy. We only got 2 comments in by the time you did an exchange and got your stent there. Tell us what your strategy is. This is an 8x40 Supera, and where's your distal landing zone for you? Where's your target?
Yeah, so first of all, I fully agree with your comment, Chris, that it's very regrettable that a 7 and 8 millimeter Supera is not available in your country. We are lucky that it's still available here in Europe, but probably not for a long time anymore. I would do the opposite. I would create Superas with even bigger diameters. But anyway, it's another discussion. Here, I'm not that concerned about this profunda. Nowadays, and you know, I'm a vascular surgeon, for me, still the golden standard for these kind of lesion, especially after already an endovascular treatment with DCBs, is a femoral endarterectomy. It's the golden standard with amazing results, not only after 1 year, but like in studies of Kang, of Balota, published in the Journal of Vascular Surgery, we notice more than 90% patency rates after 3, 4, and even 5 years. But on the other hand, there is also a dark side. If you read these studies quite carefully, there are a lot of complications, especially in more obese people where we see a very high grade of infections, lymphofistulas, and so on and so on. So if there is a minimal invasive alternative due to introductions of new technique, new devices, I'm open for this. And that's also the reason that in Belgium and France we started a trial, the VMI CFA trial, where we are treating 100 patients with the supera in the common femoral artery. We have already 33 inclusions, 1 out of 3 is included, is enrolled, and right up to now in the first controls I didn't see any loss of the profunda. So based on this I'm much more confident. The more, if there is a problem with the profunda, you can easily penetrate through the wires of the supera, going into the profunda and treat the disease at the ostium of the profunda, if you prefer.
Yeah, I
so
believe
here,
you.
now I start the implantation.
Go ahead.
Of the supera. I always start with a roadmap view to be sure about my landing zone. From the moment on, I have wall positioning with my supera. I switch the roadmap off and I switch to a chase view on field of view 16, please, where I have a very detailed and well-controlled view about the implantation. And this is during the implantation what is extremely important.
And I think we're just going to watch this because this deployment is so important. This is a calcified vessel, so we're going nice and slow on a high magnification.
So in fact, on my right hand, I have the thumb slider. This is, in fact, the least important hand. The most important hand is my left hand here, where I'm really babysitting the implantation of the supera. So from the moment on, I see that there is a trend towards elongation. I push, with my left hand, I push this device more inside the vessel in order to have a quite nominal or even slightly impacted implantation. From the moment on, you see there is a trend towards some invagination. You pull a little bit more with your left hand. And so, step by step, as you mentioned, slowly and with a very high visibility, you can easily implant this device.
This is a beautiful demonstration for the audience. This is the hardest supera to put in because it's a large diameter in a calcified vessel. So he has to prep it, which he did, and now very slow, watching every one of those stent tines come out and adjusting his left hand in amount of tension. But notice the radial strength of this stent is in this heavy calcium right away on deployment. It's widely patent. It's a beautiful lumen. And this we see this again and again. Martin, I know you saw that many, many, many times in Leipzig. Is that right?
Did you lose the connection with Vegas?
And Koen, remind us, was this Koen, remind us, was that an 8x40 supera?
Kunnen ze het zien?
I think it's 8x40. And if so, it's impressive to me that the 8mm supera did not elongate in the proximal SFA, which is just a testimony to the excellent technique there that was used.
And he's performing full lesion coverage, which is also, I think, important that you don't leave an area untreated with a stent.
No, I think, and I think he's convinced us that he could get into the profunda with a wire and a balloon because he just got a 7-French sheath easily through there in a minute. So I believe him completely. He can get to the profunda.
Yeah, I was wondering whether the deployment technique would need to be altered because of the location and the potential need to re-enter in the future, but it doesn't look like that's the case at all. In fact, perhaps the opposite, just to better scaffold that vessel. There's very little room between those struts.
So, Koen, what balloon do you have here?
So I'm using the, and I sorry, I have an important echo in my. We lost the auditive connection for a while, so I didn't follow the discussion. I'm using the 10mm balloon as we used for the vessel prep, also as a kind of post dilating balloon. I always like to create a perfect wall positioning after implantation of this device. So let's look at the final angio in the groin. Okay. So what is your opinion on this?
We think it looks, well, speaking for myself, I think it looks fantastic, especially with what you started with. I think the profunda's widely patent and that stent looks beautiful.
Yeah.
But panelists, if anybody doesn't like it, raise your hand, please. There's no hands being raised. I think there's unanimous agreement. It looks good. Now, what is your plan for the downstream disease? There was that coral reef kind of focal proximal SFA lesion and some disease in the popliteal. Is there other disease that needs to be fixed downstream or not?
So as you mentioned, now we're going to tackle this coral reef calcium in the SFA, and then we're going to focus on the popliteal. You see, you can notice there this important coral reef piece of calcium where it's impossible to pass a sheet or a device. So that's the reason that I'm going to treat this first. As it's coral reef, and as we know that probably drug-coated balloons are not that efficient in this area, I'm also planning to do a little bit the same strategy as we did in the common femoral, so never change a winning team, and I'm gonna prepare the vessel also over here, is with a 5mm balloon, 4 centimeter in length, and I keep it there for a while, and then I plan again to implant 5mm supera on this area. A nice discussion we also had in advance in preparing this case is, and I want to hear also the opinion of the panel on this. Here I'm going to implant 2 devices, 2 superas. What do you think about the implantation of 1 long supera, so covering immediately and the proximal SFA lesion and the lesion in the common femoral artery?
So let's, Martin, go ahead.
Yeah, I think putting an 8mm or 8.7mm supera in that SFA would be certainly too big, and I think that's perhaps the only drawback. If there's a drawback for the supera stent, is that it's not available in a tapered form, especially also in the popliteal segment. If you have transmission or transfer from a 5 to 4mm vessel, you sometimes need 2 stents.
Right. So you'd go with 2 stents rather than, because there's no tapering. I personally, I think while the 8 was a beautiful size, I think 5, theirs is our 5.5, but I wonder if the preparation is as aggressive as it should be. Did you say, Koen, it was only a 5mm balloon, but you're going to put a 5 supera in that heavily calcified lesion? Or do you need to treat that a little bit more aggressively before you put a supera in? What do you think? Are you going with the, what Jihad was talking about, a graded degree of angioplasty, a 5 and then a 6? Is that what you're doing now?
Yep. Absolutely, that's also the strategy what I'm following. So that's the reason that I prepared here a 6mm in diameter, 2 centimeter in length, to be more focal, aggressive on this piece of calcium. And so then after this vessel prep, then I'm going to implant supera, 5mm in diameter and 4 centimeter in length.
So. Tino.
We know that if I'm saying a 5, and probably there are some differences between Europe and the States on this, if I'm mentioning a 5mm supera, it means inner diameter, so it means a 5.7 outer diameter, what is in my opinion the perfect size for this location.
I agree. So Tino, same treatment here. We're seeing a beautiful demonstration. Would you have gone proximal to distal with your treatment? In other words, you stent the common femoral artery and then you go downstream, or would you work backwards? What do you think?
Yeah, I think it's dealer's choice, but I think in that common femoral, if you're going to work through it, it was so calcified and so irregular, I think treating it first is probably the way to go. And then you can, if you're concerned, you can place your sheath across it, and then you minimize the number of times you're going across that fresh stent. Traditionally, I think that's how we would treat this, just because of how irregular and how significant it was, and then go ahead and then treat. But I think I would be more worried about that common femoral, and treating distal through that, I think would be very difficult.
So Robert, would you, okay, great points. You treat the common femoral artery, would you have stented the common femoral artery and then worked through it, or would you have ballooned, prepped, and then stented everything on the way out?
No, I'd have probably dealt completely with the common femoral first of all, so that would include putting the stent in if I was going to put the stent in. So, like Tino, I would deal with the proximal lesion first of all and work downstream.
Okay, Koen, we're back to you. It looks like you've got a good result of preparation there. What is that enough prep, or it looks like it is? So there's their next supera.
Yeah, that's the next supera. So I selected the 540, and again I start to be sure about my landing zone. I'm starting on a roadmap, and then afterwards I switch to this chasing mode. In order, wall positioning, chase, in order to have a perfect view during the implantation, as you can notice over there. Yeah. It is a little bit impacted.
Beautiful technique.
And I fully agree with also with Martin Werner's comment. So especially the differentiation, the difference in size between the SFA and the common femoral artery makes it impossible to select one supera to treat this lesion. So with one supera. So that's the reason that we also opted for two.
So for the U.S. operators, this is an important point. The language being spoken by Koen is different than the U.S. labeling of this device. We now have half sizes in Europe, so to make up for the stents they took away from us, the 7s and 8s, they at least gave us half sizes. But the labeling in the U.S., this stent would be called a 5.5 supera on the box, where in Europe this is a 5.0, and that's an important point. So personally, we don't use, I don't know any other experience up here, but we don't ever use a 4.5 supera 4.0. I mean, it's the patency of these 5.5 in the U.S. language and above is beautiful. We don't use anything less than that, unless there are extreme circumstances. Martin, you've seen a lot of the superas. Do you ever use the small ones?
I would say perhaps in 5 to 10% of cases, especially in women with popliteal calcified lesions, 4.5 supera was used.
What is that?
It's not many.
So will you post-dilate this again, Koen?
Yes, I'm using a 640 balloon here, Armada 018, in order to post-dilate and to create the perfect wall positioning, what is important in my opinion. Very short, it's not necessary to do this in a prolonged way. I'm also going to use this balloon because this is also one of my concerns. Once you have a proximal implanted material that you can damage during passage for your popliteal treatment, that you can damage the proximal implanted stents. And so you will see over this deflating balloon, my colleague is inserting the sheet. So in order to avoid damaging the origin of the implanted supera. So, okay, perfect.
That's a beautiful demonstration of that, deflating the balloon and advancing the sheath. Sometimes in a very difficult contralateral sheath placement, you can use that same technique to get your sheath up and around. So that's a very nice demonstration. Did you have any trouble getting the last supera through your common femoral artery stent, Koen?
No, not at all. Of course, I was quite careful, more careful than in other circumstances, but there was no problem at all to pass this common femoral. So this is, voila. Okay. I think we can live with this result proximally. Look also the hemodynamics are, in my opinion, are also important. So the filling of the profunda is as fast as the superficial femoral artery, what means that despite the fact that supera is right in front of your ostium of the profunda, there is really no flow limitation at all.
We agree.
Chris, what do you think about that lesion right after the common femoral artery stent?
I think it looks okay. We'll have to go back and take a second look, but it's so far so good. I think the profunda, as Koen said, the flow was completely fine. if there was a 40% narrowing, I wouldn't touch it with, not even think about it. Then you're treating your eye, not the patient. So I think it looks very good. And you can see the heavy calcium exists down there in the popliteal as well. Herb, given all this, you've seen the superior is performing beautifully. Now it's a fairly focal lesion right behind the knee joint, but there's heavy calcium. Are you thinking balloon, DCB, and provisional superior stenting, or would you just go ahead and just hit it hard and put another superior, since so far we're 2 for 2 with the superior? What do you think?
Yeah, it's a great question, Chris. I don't know if there's a right answer, but I actually like your first proposed approach. I think I'd balloon DCB and see if I can get away with it, but if I couldn't, I wouldn't feel bad about putting a superior right here. I know it would perform very well.
So what do you think, folks, if we have to go with a smaller superior, let's say we have to use a 5.0 in the U.S., and you've got that, is there a role for DCB and superior stent to maybe lessen the restenosis? Any thoughts?
I think it's hard to know. We don't have a lot of great data on that. There's a calcified lesion, so we might suspect that we might not have the same efficacy from the drug therapy, although this is an area with a smaller vessel in the popliteal artery where I think if we can get some biologic working for us, that there might be some benefit. But these are typically lesions, I think, that are difficult with drug therapy, and then oftentimes do require scaffolding with that heavy eccentric calcification. I think Supera, the data shows that it performs very well on this location.
Tino?
Yeah, I don't consider us very aggressive with atherectomy, but this is one area that I may consider that. It's a focal area plaque, it's calcified, with goal of hopefully not placing a stent, atherectomy, drug-coated balloon, and see if I can get away.
Which atherectomy device would you use? Is focal, it's in the calcified in the popliteal? What do you think?
I think in this area, almost all of them, it's such a focal area, would probably do well, whether it's a jet stream, whether it's a directional atherectomy, even rotational atherectomy, I think could be helpful here.
Great,
it's such a focal area.
I agree. So, Koen, what balloon do you have here that you're using in the popliteal?
So now we are preparing the popliteal artery with a 440 balloon. You see quite small, the bigger the common femoral is, the smaller the popliteal artery is. So we are preparing quite carefully here, and my idea is, as I consider still the popliteal artery as a no stent zone, I will try to treat this with a drug-coated balloon. I fully agree with the remarks about atherectomy, but you have to take in account if you have to do first an atherectomy first in the common femoral with a big device. Afterwards, you need to do an atherectomy with a much smaller device in the popliteal. You need to combine this with a distal protection device, and you need to combine this with drug-coated balloons, and probably afterwards with some scaffolding. At least in Belgium, this is an unpayable procedure. This is point one. Point two, I still miss some evidence concerning the atherectomy combined with DCB. I know that we have like definitive AR and so on, but in very small amounts of patients. So I'm still not convinced about this strategy.
So it looks like, as we're discussing this, because you're doing DCB, you're leaving your balloon up longer for your inflation. So the difference here is, back to your point about good angioplasty, a long inflation, and then relook. Is that right?
Yeah, this is completely right. And also this is also taking part as of our strategy. I mean, in a lot of, let's say, regular cases, we are performing an angioplasty, a vessel prep with a POBA balloon first. Also in the same way as I explained, just to see if the lesion is an angioplasty responder or not. If it's fully dissected from the beginning with a careful vessel prep, I don't consider this as a good angioplasty responder, as a good DCB responder, and I opt immediately for a scaffold, a stent. If it's a good angioplasty responder, then I prefer to do a DCB treatment. So in fact, it's a little bit judging with my POBA, with my vessel prep, judging which kind of lesion I have to tackle. So here I selected a Stellarex drug-coated balloon of Spectranetics. I selected a 5 millimeter in diameter and an 8 centimeter in length. We all know, I think you heard a lot of presentations during VIVA about this Illuminate. We have the first in human, we have the pivotal trial, we have the Illuminate global results, all fantastic results. And so based on this, I think it's a quite good balloon to treat this popliteal artery.
I think you're right. There, you know, the data was 88+% primary patency, so it is very good data. Happy to see. Martin or others, what do you think, any role, there's a question from the audience, I think a very good one. Shockwave here. What do you think for this calcium shockwave and then DCB? Is that an option? And what do you think?
That is an option indeed, and I think it's a very interesting field because especially in calcified lesions, it's unclear if DCBs work efficiently, and so with cracking up that would be a good concept actually. I like Koen's pragmatic way to treat these lesions, talking about PTA responses. It's interesting to see how much attention plain old balloon angioplasty is getting in the DCB area. And I think that's a very good development right now.
I agree. Robert, do you think, you know, you've seen all these DCB trials, if you look at one of the most surprising things, not only how well the DCBs do, but how well the angioplasty arms do compared to what we're used to thinking about angioplasty. They're now 60%. Is that good angioplasty technique? What's going on there?
Yeah, I think what the DCB trials have taught us is that a prolonged balloon inflation really does improve the results of angioplasty across the board. So no, I'm very pleased with the angioplasty technique being used here.
I agree. So if you did shockwave, would you still add the DCB because it's a smaller vessel for the biologic effects and treatment, or would you see what your results were with shockwave alone? Any thoughts from anybody?
Well, actually, we have no data on that.
Sure.
So I think it's going to be investigated in the next shockwave trial, and with that data, we can answer that.
So since we haven't had it, Mark, tell us just a little bit, how's it work? Is it an easy procedure to perform? And
the shockwave,
yes.
Yeah, actually it's a balloon-based procedure, so everybody using balloons is quite familiar with how to do it. It's small different steps to do, like not to use too much inflation pressure and a little bit more time than normal PTA, but the learning curve is very fast because it's not a new technique to adapt really. It's based on balloon angioplasty.
right. So again, even in a live case, Koen, we love that you're living what you're talking about here with the good long balloon dilatation. So we applaud you for that. A lot of times in a live case, if you're not careful, you want to come up, you want to come down. You're demonstrating for the whole audience that you're doing what you talked about. So thanks.
Yeah, and I agree with you. During live cases, this is even more difficult than during the regular live, especially for a quite impatient vascular surgeon to wait minutes and minutes and minutes to do everything slow. You need to do the implantation of the supera slow. You need to do the vessel prep slow. So it's a hard life, yes.
The good news is you have the world's most patient panel up here. I'm looking to my right and left. These are patient folks. They're loving this. So as the balloon comes down, Herb, so now you're in a new role at Brown where you're kind of overseeing things, and cost has got to be one of the things you're talking about with your administration as they talk to you and you lead your team. Do they tolerate procedures like this with 3 lesions if you use a distal protection and a atherectomy device? Is that something that's okay, or you do it selectively, or how do you balance that?
Yeah, these are important questions now, and I think in the coming years will be even more important everywhere. But in particular, I'm speaking to our situation in the U.S. healthcare system. I think, like many labs, we have room to become more sophisticated. I think we probably aren't looking as closely as we could at this. Usually, I think as operators, we're thinking about what's the best thing I can do for my patient based on my interpretation of the data, but we may not always take pause and say, well, if I add that protection device, if I add that drug-coated balloon, and then I end up putting a stent in as well, what am I left with at the end of the day, and what does that do to the system? So, I applaud Dr. Deloose for his comments about maybe not making this any more complicated than it needed to be. We're not quite to that point yet, I think, in the U.S. Where they're cutting off the supply of money, but I think we're going to need to look at things in that light, especially in the absence of good randomized data to support a lot of what we do in the lab.
Okay. So let's look at this angiogram together, Koen. What are you thinking here? Tell us your thoughts after the angiogram, and then we can get the panel to weigh in as we need it. Looks like it's responded pretty nicely. There's a little bit of narrowing right at the knee joint. What are your thoughts?
Yeah, you've seen, so we did 2 projections. I had already some doubts concerning the first projection. And I had also some more doubts if I look in an LAO 25 degrees. So what we can do now is a quantitative vessel analysis, and we will measure intraoperatively with our workstation here on table. We're going to measure the stenosis, the degree of stenosis. And so if you see there the results, probably I think it's slightly underscored, but we have like more than 37% stenosis. So in my opinion, I think also knowing that we did the vessel prep in my opinion, a very good way, that we left the Stellarex balloon inflated for more than 3 minutes and a half. So you can redilate again and more, but at one moment you need to decide to use a scaffold, yes or no. So in this situation I decided, although I don't like to implant in popliteal arteries a lot of metal, but I decided here to implant a third supera.
So, Koen, before you do that...
What is your opinion on this lesion?
So I think that's a reasonable strategy. My opinion would be that you pre-dilated with was that a 5.0 drug coated balloon? And it was a 5.080, so it was a long balloon. My concern would be going straight to supera here, that you may get a little elongation. And the question is, would you take a 5.5 millimeter balloon or something shorter and more focal for a little bit more prep before you put the supera in, or are you comfortable that this is enough prep?
I selected a 4 millimeter supera, so to overcome this problem, the maximum dilatation based on the fact that the vessel is, I think, like a 4.5. If we measured on the quantitative vessel analysis, it's about 4.5, 4.6 millimeter. So if we take in account a 1-to-1 implantation, I think the 4 millimeter inner diameter, so 4.6 outer diameter supera is the correct choice. And I prepared with a 5. So I think it makes sense to go directly for this supera implantation.
Okay. Chris, just a quick question. If you were to go back and post-dilate this narrowing area in the lesion, what is the practice in Europe right now? Do they go back with a DCB? Or just use a plain balloon to treat that narrowing?
I think if you're within the drug treatment zone, there's no reason to add another DCB there, but you do need to stay within the treatment zone. That's an important point, and I think using a short balloon to stay within the drug treatment zone so you don't have mismatch.
So there's no need for a secondary DCB?
I don't think so. So let's watch here. This is implantation here. I think with the 4, he's going to get a nice deployment. My own experience with the 4 is the different ways to do things. I personally would make it a 5. And this is the beauty of having a half size in the U.S. I would use a 5.0. But I think if you're using a smaller supera to overcome the restenosis that's inherent with a smaller device, the DCB may help. There's not data, but I think it's a good strategy.
Yeah, I agree with you, Chris. I think if I had here in Europe a 4.5 available, for instance, then I would implant this 4.5. I agree with you. But the 5 for me was a little bit oversized. Here means a 5.6, 5.7 outer diameter. And for this vessel, it's too big, and I'm going to end up with an elongated implanted supera. And as we all know, out of the SUPERB trial, that the patency rates are really dropping in an important way if you implant the supera elongated. So that's the reason that I wanted to be sure and safe concerning this.
Excellent points. Tell us a little bit about your CT technology there. Does it give you accurate measurements of the vessel size? You know, it's doing so many things for you. Does it also give you an accurate measurement of the vessel diameter? And have you correlated that with IVUS? And what do you think? Which one's more accurate? And tell us about that.
Yeah, I'm not extremely familiar with IVUS, so if the vessel is not extremely calcified in terms of sizing the diameter, it's very easy and very accurate on these pre-op CT. Also in terms of length, what I like a lot, and I'm going to present this in the second case, it's in terms of length measurements. What is also important in selection of devices and so on, it's the stretched view, the possibility of making a stretched view like we do in aortas. You can also do it in peripheral arteries, and it gives you a perfect sizing about length and also diameters. So when it's extremely calcified, like in this case, it's a little bit more difficult to judge in the correct way the right size in terms of diameter. Also the markers, and I had a comment on the fact that the yellow ring was not perfectly on the ostium of the profunda. This was fully correct, and just because of the calcium. Because of the calcium, it was impossible to localize in a very precise way this marker. So calcium remains also on pre-op CTs the biggest problem to overcome in terms of perfect sizing. I don't know with IVUS if this is also influencing your results.
Good. Tino?
Chris?
I really think this point about the image fusion is really important. I think the future is going to be being able to bring all the information, whether it's going to be our 2D ultrasound, fuse in, CT type information onto our fluoro screen. You can also imagine having the opportunity, even IVUS information after you've gone through with an IVUS, actually have that there fused, and as you're doing the procedure, that information is there for you. So just like being able to identify the profunda, you can identify where the lesions are, where the high velocities are, and all this information is at your fingertips as you're working. It's going to help with time. I think it will help with radiation and definitely with results.
Less contrast, everything. Darren, you were going to make a comment too, I think?
Yeah, I wanted to see if we could talk a little bit about the post-dilation strategy with the Supera. We've talked so much about the importance of vessel prep, which is absolutely critical, but do we dilate them selectively? Do we dilate the entire stent? I've tended to use a shorter balloon with some focal pressure in areas of persistent narrowing. I mean, what should be our strategy here?
So that's a great question. I'll start. I think personally, if it's a beautiful result, if you prepped it perfectly and it looks beautiful all up and down, I don't even think you need to post-dilate personally. We post-dilate if there's a problem with the stent, if there's a little bit of area of elongation or overpacking, and I'm with you, I use a shorter balloon. Others, thoughts?
Yeah, that's exactly what I do. I usually use a short, sometimes slightly oversized balloon to try to iron it out and open up that area of persistent stenosis.
Let's watch your runoff. And now this is going to be interesting, right at the trifurcation, and we'll get some comments here. It's been it's a beautiful demonstration here. Let's let him play that.
Looks like a lesion at the trifurcation, doesn't it?
Yeah, so Robert, what do you think of the angiogram here? And then Koen, we're going to turn it back to you.
I'd like to see the original angiogram just to see that was there all the time.
And I would pull back the wire as well, which would make perhaps an artifact.
I'm also thinking ahead as to what closure device they can use with a stent in the common femoral artery.
I think it's called 5 fingers. So Koen, tell us about the procedure runoff angiogram and then what you're thinking now.
Yeah, so I think, wait a moment, I go for these, I want to see this breeze, voila. So I think here in the SFA, in the common femoral, everybody can be very happy. Flow is fast, as fast in profunda as in the SFA. Also the proximal coral reef piece of calcium in the proximal SFA is treated in a nice way. The wall positioning of the supera is quite perfect. And then, so if we are going more distal, I think also everybody can be agree with the popliteal, but I am also in doubt what happened at the trifurcation distally. So I want to see this more in detail, and I want to compare also with the, and I need to ask this to the technicians, that we can compare with the preoperative breeze to see if there was already this piece of calcium at the trifurcation from the beginning. So yeah, there we go. So I'm gonna, it seems, although it's also in another projection, but it seems that it was free over there. So let's focus now on this trifurcation.
So it looked like there was at least mild to moderate disease even at the onset, which wouldn't take much from that calcium to lodge there.
Yeah. So you see this, yeah, this is quite clear. There is a very slow flow now. There is a faster flow in some collaterals, filling the tibial vessels, and then afterwards, so there is definitely some distal embolization at the trifurcation.
We agree. Okay. Luckily, it looks like it's very focal, so you'll be able to deal with it. So as you're getting ready...
It's very focal?
Yep.
Yeah.
So Jihad, what would you do with this?
I definitely would take a large bore catheter and try to aspirate first, and if that doesn't work, then balloon it.
Yeah, focal force balloon, since you're at the trifurcation?
Yeah, small focal force balloon.
Tino, would any role here for a aspiration catheter, simple export or pronto or whatever your aspiration choice?
I mean, I think there are all those. We usually would just go down here with a catheter of some sort. So here we'll probably use an Envoy. We have a 7 French sheath. Go with a 6 French Envoy. It's a kite cath. You have a good, a big ID and aspirate. And if that doesn't work, then consider maybe some other suction thrombectomy or penumbra or something like that, and then go to an angioplasty if necessary. Such a focal area may just go straight to the angioplasty after an attempt of aspiration, but usually have very good results with those aspirations.
That's a good point. When you use something like that with an indeflator, you get an immediate 650 millimeter mercury, so whatever is sitting there is going to get sucked into that large bore.
Tina, do you have much experience with the penumbra aspiration device?
Yeah, we've had a large experience with that, particularly in the arterial tree. We published a couple of years ago, looked at, I think, something like 30 patients. Very good results with embolization.
That's a great
question. Now they have bigger catheters. That's before the 6 French and the 8 French catheters.
So, Koen, what are you doing here? This looks like a fairly long balloon. What are you doing? What's your strategy or plan here?
Yeah, as I'm sure, based on the nature of the lesions we treated over there, it is a piece of calcium. I'm not so enthusiastic about all these aspiration techniques. A big piece of calcium is quite difficult, more difficult than thrombus. This is my first point. My second point is, that there are already 2-3 stents more proximal, so passing all the time with these kind of devices can damage. So that's the reason that I opt first to dilate and probably to compress this piece of debris in the vessel wall, and we will have a look if the result is acceptable with the dilatation only. I leave it like this. If the result is not acceptable, then I try to capture it with a very short, with a small stent. So that's my strategy that I'm going to follow here.
So what balloon is this that you're using?
So this is an Armada 3 millimeter balloon and 4 centimeter in length, over an 018 wire, still the same wire as we started with. Probably it's a quite good idea. If we need to stent, I'm gonna use a dedicated below the knee stent. So I'm gonna need an 014 wire. So through the balloon, we can already prepare ourselves and exchange the wire, an 018 exchanging into an 014 wire. I'm going to use a command wire of Abbott Vascular to tackle this below the knee area.
Yeah, we like that wire as well. It's a beautifully steerable wire. Go ahead, Tina.
I like the prolonged inflation here. I think this is where you want to be patient, put the balloon up.
Yeah.
Because this is the best way to get out of this. So I like
think
this idea here, and just take your time and be patient.
I agree. I think it's a focal lesion. There was some disease there to begin with, and I think if it yields, then you won't have to put a stent in the trifurcation. In the U.S., if you had to stent, he's talking about a dedicated stent. We'll hear what that is. In the United States, gentlemen, what stent, if you had to put a stent there? Darren, what would you do?
In this location, I'd probably use a drug-eluting coronary stent.
I think that's the point, a short focal drug-eluting stent, because it's at the trifurcation, it's a very important point.
Right, you can place it precisely, you can get the right size, and the data shows that the use of the drug-eluting versus the non-drug-eluting in this location is worthwhile. I probably would have aspirated this first because you might have gotten away with not having to put an implant in here, and oftentimes, I think with the appropriate aspiration catheter, you can suck that out, but certainly then the next step would be to do exactly what Koen's doing here.
Yeah, I share Koen's concern about the calcium. It's not the same. The penumbra, we talked about, that's a great question, Robert. I'm not sure penumbra would work with calcium like it would with thrombus, and I don't think this was a thrombotic piece. I think he's right that was a calcium small chunk in pre-existing disease.
I think it all depends on really how big it is, and basically if you can vacuum it into the tip of that catheter and pull the catheter out, you may get away with it.
Yeah, I would have to say that also, that we've had some very good results, even with calcium. The amount of vacuum that you create at the tip has been surprisingly helpful. But that being said, I'd probably try a catheter first.
Yeah. All right, so let's look at the...
It's cheaper.
All right.
So as you can notice, there is still a piece of tissue, a piece of calcium over there. It's even more clear now than before. So definitely I want to scaffold this. I want to treat this with a stent, a short focal stent. The reason that I switched to an 014 wire is that I already had in mind to use an 014 compatible stent. So here I opted for a Science V stent. It's a drug-eluting stent, everolimus-eluting stent. We know out of 3 or even 4 randomized trials below the knee that for short focal lesions, these drug-eluting stents are doing better than the regular stents.
I like it. So where will you place the stent relative to the trifurcation? And is there any other view you want to take? You've got a little slight ipsilateral angulation. Any other views before you place the stent, or do you use your technology from the CT as well? How will you place the distal end of this stent?
No, yeah, it's a good remark. I think my experience is if we will take another view. But if you are really on the trifurcation and you really want to end right in front of 1 or 2 of the vessels, that you always end up with a difficult situation. So in my opinion, you really need to select one of the vessels and go for it. And if necessary, going through these stent struts and treating the other vessel. So, but let's see in another projection here. So, I'm a little bit in doubt, as these anterior tibial seems to be the most important outflow vessel. I'm a little bit in doubt to re-steer my wire to go to this anterior and implant the Science V to the anterior. What do you think about this?
I mean, the other approach would be to put a second wire down into the AT and perhaps stent in that direction, and then it looks like it'd be more favorable to recross in the TPT through a stent into the AT. I don't know what others think.
I like that. And what you can do is take an 035 catheter over this 014 wire. You never lose. You don't have to rewire anything, and then you bring your second wire down through that catheter. As you're working there, Koen, I'm sure with all the excitement and the long cases that's going beautifully, what's your anticoagulation? Do you check ACTs in a situation like this, or do you have a heparin drip going? Maybe your partner can answer that while you're working.
we don't check routinely ACT. So I'm administering 7,500 units of heparin in the beginning, and so after like 1 hour we add some more units. So we definitely not check these ACTs during procedure. You see with the command wire, it's a nitinol, it's a hybrid wire also with Durasteel and nitinol. It's a steerable wire, you can shape it in a very easy way. And so based on this, you can implant your stent. Can I have the stent, please? Yes.
So, King,
and then, yes?
So I just want to keep you posted on time. We have about 1.5 minutes, so there's no hurry. You've done a beautiful demonstration the whole time. I just wanted to let you know. Hopefully we can see the stent implantation in an angiogram, but it's going smooth. We're just going to keep watching what's been just a fabulous demonstration. And as you're getting...
Thank you. So my goal now is to implant the stent at this area. I selected the science V 3.5 millimeter in diameter, 2.8 centimeter in length. And so then afterwards I will try with my wire to go through the struts into this tibiofibular trunk and also dilate again this tibiofibular trunk. So in order to restore the full trifurcation, and probably I can show you during the second session, I can show you the final result of this trifurcation.
Well, Koen, the other thing is a reminder, you will still be, the audience will watch you 15 minutes even after we go off the satellite. So they will be watching, and I'm sure, believe me, everybody has watched very intently. So they will be still watching you so you can complete this in good time fashion. So
that's a great idea.
So what we'll do, if we can, is just get an angiogram now, and then you can work and everybody can watch. Again, it's been a fabulous demonstration. We appreciate you and your team. Just a great, great case. So it looks great. It's a trifurcation, into the anterior tibial. Like you said, you'll have to rewire probably the tibio-peroneal trunk. But what we're going to do is we're going to go ahead and go on, and the audience will continue to watch you. And as we go on to the next session, Koen and team, fantastic job. Thank you very much, and we'll continue watching. So I'd like to thank the
panel for your comments, and we're going to turn this over to a very good session with lots of case demonstrations, and I'll turn it over to John Kaufman.